Okay, so my name is Thomas Elliott, and I would like to welcome everybody to session 86 of the International IVF Initiative. I'm currently in Atlanta in the IVF lab at Reproductive Biology Associates, which you can kind of see behind me, and then maybe a few embryologists that you can see walk backwards and forwards a little bit later. It is a great honor to be co-moderating this session with my colleague and fellow Brit, Giles Palmer. Giles needs very little introduction. He's the engine that pretty much drives I3 and has achieved so much already for the sessions, the topics, the speakers, done some fantastic work. So thank you, Giles. Now, Giles and I could very happily continue speaking about the music scene from the 80s or sci-fi movies. And Giles, may the force be with you.
Indeed, indeed.
But tonight we've got a session which is all about innovations. The session is called Small Objects of Desire.
Thank you, Thomas. I wasn't expecting the intro. As we said, we're going to keep it short today because we've got really a lot to get through. But it is a great honor to be with Thomas. I met him through I3, and we really do have a lot in common, as you just mentioned, but also our love for everything IVF. Now, of course, Thomas is the co-founder, if you like, of I3, but he's also the founder of IVF.net, which you all know. And he has his own small object of desire, the Cryo Sentinel. But you'll hear a little bit more about that later, and there'll be a special room in our network section for that as well. So today we'll have two presentations, and then we'll have a Q&A, and then we'll have a very special network event. There'll be a hard stop on the hour, and you'll be given a link and then a password so you can get in and experience this for yourselves. Now, we are trialing this, so be kind. Information has already gone out to the people who have the electronic membership cards, so I hope you all have them with you as well. And any changes to the program, they'll be put on there as well. But without further ado, over to Thomas again.
Fantastic. So our first speaker is actually sponsored by Mays Men's Health in New York and MFC Global Limited. It is about a device for recovering minimal quantities of sperm. Chaya Rothschild will be presenting. She began working in an art laboratory in 2015 and joined Mays Men's Health in 2019 as a project manager for extended sperm search and microfiche. She joined with the MFC research team to implement their single sperm freezing technique for the first time in the US. Chaya holds the AAB certifications in embryology and andrology laboratory services, andrology sciences, and is currently pursuing her master's degree. So Chaya, please take it away.
All right, so thank you for that introduction. And I'd also like to thank whoever provided us with a very cryptic introduction in the Q&A of session 85. For anyone who didn't catch that, you can go back and check it out. But today I will be speaking about my experience using the Sperm VD for sperm vitrification. My disclosure today is that I'm employed at Mays Men's Health. I worked for several years in a typical IVF lab before joining the dark side of urology to be the project manager for our ESSM. So I'd like to ask everyone to take a minute and think about the worst ICSI case of your career. Unless it was a TESI case, chances are you saw sperm for that patient before you got in front of your ICSI dish and you couldn't find sperm, right? Or couldn't find good quality sperm. And you spent hours searching for something you can inject. And then you went home at night asking yourself, if I looked harder, if we had planned differently, would the results have been different? And or maybe you didn't find sperm at all and you had to freeze those eggs. We were all raised on the mantra of if there's one sperm, there will be more. But occasionally this does fail. So these patients are generally counseled before we get into their IVF cycle about what options are available. So we start with telling them we're going to freeze a whole bunch of samples. So we have a backup. And we in the lab know that the likelihood is that those backup samples are going to be even poorer quality than what you might see in the fresh that day. And so you tell them, if we don't have sperm that are viable, good quality, or sperm at all, then we will have to freeze the eggs. And so if they want to avoid the risk of potential cycle cancellation due to insufficient sperm, then they can elect to do a testicular biopsy, or they can select a donor sample as a backup. And it's through this lens that we began to explore what other options might be available to improve outcomes. So our patients, these patients fit into one or several of the following categories. For virtual azoospermia, this is defined as the occasional presence of rare sperm in the ejaculate. So it's important to differentiate this from the rest of the groups, because for these patients, we have sperm one day, we may not have sperm the next day. But also these are the patients where you don't see sperm in the semen analysis. You don't see sperm on your initial slide. Even when you spin it down, you don't see sperm. And it's only when you plate the whole sample in an ICSI dish and go digging for clams that you may find rare sperm. It's our cryptospermic patients. So these patients have the consistent presence of sperm at a quantity too low to be observed in the raw sample. So you make your slide and you don't see anything. You spin down the sample, and then you start seeing some sperm. Our asthenospermia patients, so they have sperm, but you are seeing low or no motility in the sample. Our patients who are about to go or have already undergone a medically sterilizing procedure, and it's our TESI patients. Collectively, the scenario here is we're used to thinking of egg quantity as our limiting factor for IVF ICSI, and for these patients, it's the sperm. So we implemented this sperm vitrification protocol at the end of 2019, and we have just crossed over the 200 patient mark of people who came to us with the collective diagnosis I like to call, go to the urologist and come back with sperm. And for our cryptospermic patients, we've been able to find enough sperm for ICSI in every sample we look at. For these presumed azoospermia, virtual azoospermia patients, we occasionally find sperm, and I broke it down here a little bit to give you a good idea of who we've been successful at finding and freezing sperm for. Our astheniospermia patients, the sperm is there. The question is, right, can we find anything motile, anything that you would want to inject? In about 60% of those cases, we can find a rare motile sperm and just freeze that one or those few. For our fertility preservation and TESI cases, right now I'm still using VIT on a case-by-case basis. And the reason for that is because I don't want to limit the availability of which IVF centers they can go to with these samples when they're ready to move on to IVF. And hopefully, as more labs become familiar with sperm vitrification, we can expand our use of it as well. An efficient sperm method for individual sperm vitrification is critical anytime we're worried that there might not be enough fresh sperm to do ICSI. We want to reduce the need for TESI in non-azoospermic patients. We want to reduce the need for repeat TESIs, and we want to prevent cycle cancellation due to insufficient sperm. There have been previously published attempts at sperm vitrification, and the one issue that came up over and over again with these other protocols was that these little dudes are tiny, and they are so very easy to lose. And the challenge was, however many sperm you put in is not always the amount of sperm you take out, with perhaps the exception of the empty zona protocol. And the challenge there was that this will never receive FDA approval because you're using a biological substance. In order for sperm vitrification to be a reasonable alternative to what we're doing now, we have to be able to see recovery of most or all of the cells we put in, survival of those cells. We want to see what the fertilization, pregnancy, live birth potential looks like. And ideally, it will make the lives easier for embryologists in what is right now your most challenging ICSI cases. And so in 2018, this paper was published in Human Reproduction Journal, implementing the Sperm BD for use in virtual azoospermia patients. They displayed a 96% cell recovery rate. They reported an average 59% fertilization rate and a 55% pregnancy rate. So to use this device, I start by collecting the sperm that I plan to freeze into droplets of clean media with an ICSI setup. When I'm ready to freeze, then we prepare the device itself. There are 3 wells, and they each hold a 1 microliter droplet of a 1-to-1 solution of sperm wash and sperm freeze. And then the whole device is placed into your dish under oil. The sperm can then be transferred from the media droplet onto the device itself. The whole device goes into a cryovial and gets plunged into liquid nitrogen. To thaw the samples, you do the same thing in reverse. The vial is removed from liquid nitrogen. The device is placed on your heated surface, and those droplets liquefy within just a couple of seconds. And then the sperm can be removed from the cryomedia droplets, placed into clean media in your ICSI dish, and then you can inject. Another scenario where sperm vitrification can be beneficial is where sperm concentration may or may not be an issue, but it's when you have a single sample and you want to aliquot it for multiple ICSI uses. So for this, I concentrate the sperm sample. I will add 1-to-1 cryomedia just as you would if you were putting it into a vial, and then place droplets of the suspension directly onto the device. I think the most critical place where this can be implemented is for our oncology patients, where we get 1 sample today and they may be starting chemo tomorrow. I use this method a lot for my borderline oligospermic patients who have counts of like 1,000 to 100,000. So if you freeze it in a vial, the survival is going to be really poor, but we want to maximize what we can freeze. And another interesting use here can be for donors. Either that scenario where you have a patient with 1 donor vial, you're thawing it for ICSI, and they want you to refreeze that vial for another ICSI chance down the road. But this may be an interesting use for our known donors with low sperm counts as well, because we're limited by how many samples we can freeze for them by our the FDA testing window. So about 1/3 of my patients have been referred by fertility centers, and the rest of them are finding us on their own. So after I freeze sperm for them, I'm usually reaching out to an IVF lab that hasn't heard of us, hasn't heard of this, and their patient has sperm and they want to use it. So their first question is, what have you done to me? But then their next question is what they can expect in terms of survival in comparison to slow freeze. So this was a poster presentation in ESHRE 2019. It was a randomized sibling oocyte study of testicular sperm that were divided into aliquots of conventional slow freeze versus vitrification. And the outcomes in terms of fertilization and blast rate are fairly comparable, but what's interesting here is the microinjection time, and you can clearly see that the actual process of doing ICSI was just so much easier for the embryologist. And interestingly enough, the bulk of the embryos were selected for transfer based on typical morphology evaluation, but were primarily 80% were from the vitrification group. I don't have very many scenarios comparing ejaculate sperm in vitrification versus slow freeze. And the reason for that is because most of our patients don't qualify for slow freeze. If a virtual azoospermia or a cryptospermic patient, if we're not seeing sperm in the sample, we're not going to freeze it. Even for some of those astheno patients, if you don't see motile sperm, you could argue is there a benefit to freezing? And then when you do freeze, to your credit, most IVF labs will really push themselves to use fresh, and the slow freeze samples don't get thawed. But I have this case report for you. This was a patient who did one IVF cycle with slow freeze sperm and one IVF cycle with vitrified sperm. And so just when you look at the sperm post-thaw motility, you can see that that second ICSI was going to go much faster and easier than the first one. What's also interesting here was the difference in euplity for the embryos they tested. The original study did not include PGT. Most of my patients in the US are using PGT, so we'll see if how that data pans out in terms of more than one patient. But as opposed to the last case where we talked about time for ICSI, here I want to talk about time to IVF. Before their first IVF cycle, we froze 9 samples over the course of 6 months. Only 2 of those samples had post-thaw motility. Those samples were thawed for ICSI. So immediately after their first cycle, they came back to start banking again to prepare for the next cycle. And this is where we offer them vitrification as an alternative. We froze 1 sample. The IVF lab was comfortable with the amount of sperm we had then, and they did a retrieval with her next cycle. And again, embryos were selected based on morphology. They were selected from the vitrification group, and this resulted in live birth. Sperm vitrification has shown itself to be an efficient, safe, and simple method for us to utilize for our patients. It reduces the workload for the IVF lab from hours to minutes. We see a nearly 100% sperm recovery rate, which has been the biggest challenge with sperm vitrification previously. And we can help prevent the risk of cycle cancellation and unnecessary TESI procedures. I want to close with a case report. This was published in the Indian Obstetrics and Gynecology Journal just about a year ago. This was a case where they did fresh TESI on the day of retrieval, and the excess sperm was frozen on a VD. The couple then elected to do a second retrieval to accumulate more embryos. The embryo selected for transfer was from the vitrification cycle based on morphology, and resulted in live birth. The quote is, "Efficient single sperm freezing protocols will help to avoid the risk of cycle cancellation and repeated testicular surgeries, and will go a long way in giving hope of parenthood to these couples." Thank you everyone for your time and attention. I look forward to taking your questions.
Thank you very much. That was excellent, and we've already got many questions, and a lot we'll talk about a little bit later. But you've got quite an unusual a title, haven't you, at work? Would you say?
Yes. I find that it's much more helpful for the patients than it is for the embryologist to describe what I do as micro freezing versus vitrification, to kind of give them an idea of how this is different than what's been made available to them before.
Mm-hmm. And you spend all your day fishing for sperm, would you say?
It's not the first time I've heard that particular term. I prefer panning for gold. I like to think that it takes a little more skill. I apologize to any fishers out there that
There you are, yes.
exactly what goes into that, but I like to think that this takes a little more technique.
Okay, great. And the device is available globally or just in the States? Just to know.
Yeah, it is. There are global distributors.
Okay.
I know all
Okay.
of that.
Okay, well, thank you very much. We'll come back to you later. Now I'd like to talk about our next talk. It's going to be about AI and sperm selection. This is sponsored by IVF 2.0. The owners or the people behind the system Erica, which is of course the AI system for ranking embryos, for having an embryo score. Today we're going to look at sperm and how they can be chosen using AI from within an ICSI dish, I believe, using a novel technique called SID, sperm identification. It's going to be presented by the company's CEO. He's a medical doctor as well, and he's also now a PhD student, now living in London. So I'd like to introduce Dr. Alejandro Chavez-Badiola to give the next talk.
Thank you very much for the introduction. We humans are fascinating creatures. We dream, we design, we create what can help us to overcome our shortcomings. My name is Alejandro Chavez, and I will be presenting to you in this session of Objects of Desire, SID, which is a tool that I believe can assist embryologists in the near future during the sperm selection process. My conflicts of interest have already been mentioned. I don't have any other conflicts of interest. And before I present you SID, I would like you to imagine yourselves walking in this fantastic Italian field. Now, indulge yourselves with all your senses. Think about how the sun might feel, the wind, the smells of all the plants, all the trees, and of course, the beautiful day. It's very difficult that you could imagine that you are walking past probably millions of dollars just beside you. But of course, we were not designed to identify truffles just by smelling, because our sense of smell is not good enough to identify them. But the people that unearth these delicacies understand their limitations, and they very quickly found ways to find truffles with the help of assistants that can help them overcome their limits in the sense of smell. So they use pigs, they use trained dogs, and in this way, they have created an entire industry. Now, we humans are very good usually at understanding our limits. We've got used to employ tools to overcome these limits. And because our eyes, for example, were not designed to measure volume, temperature, altitude, speed, we have designed the tools that are needed to assist us to understand and appreciate the world in a different way. These tools allow us to get from where we are into reaching our goals. And probably equally important, these tools allow us to avoid getting from where we are into nowhere or into a nightmare. Now, the question is, what is it needed to get from good into great? Because again, we humans are very good at dreaming and we always want more. We were able to fly, now we want to colonize other planets. Well, we need dreams, and of course, we need access to better technology. And this is probably a crucial step. One clear example is the history of IVF. You can see on the right how the initial lab was designed, generated, and the more modern labs. And of course, with the introduction of standards of quality and trying to standardize everything that we do through the use of tools. One of the areas in which this is not clearly improved is during the sperm selection process. In particular, when we're talking about individual sperm selection for ICSI. Why? First, because all the references that we have are very subjective. And this, I just took it from the new 2021 OMS or WHO manual for sperm. And you can go through that and read it. Take all the time that you want. Now, take a look at the definition of what is normal about the head, the midpiece, the tail. And for example, the tail, it says that it should be approximately 45 micrometers long, about 10 times the head length. Now, fantastic. Try to do it now. Can you really measure the head? And how about the speed? Our eyes are not designed to identify the speed, to assess how fast a sperm is rotating. And of course, we only have one pair of eyes. And because of this, it's very, very difficult for us to identify and to compare, once again, in real time, every single sperm under the vision field. What is the result from this? Well, practically, we are leaving our embryologists to put their eyes on the microscope and to subjectively try to identify all the patterns that they believe are relevant for sperm that could make a difference in outcomes, defining outcomes as normal fertilization and blastocyst formation. But of course, as you can expect, embryologists don't seem to be that much consistent when they're selecting sperm. But again, it's not their fault because the initial parameters that were designed to tell them which sperm are best are very subjective. What is our response to that? Of course, some research and tools. But up to now, most of the tools that have been designed to improve sperm selection for ICSI are meant to improve the population. This is, if we have million sperm, we have to design a preparation that is going to improve the proportion of top quality sperm in a very, very small sample. And we have microfluids, we have MAGs, we have PIXI, and of course, IMSI is probably amongst the only options that allows real-time individual sperm selection. But for whomever that has tried to use IMSI in a normal sample, it's almost impossible because the magnification is so ridiculous that it's impossible to track sperm that are moving fast, which at the end, once again, leaves us on our own to select one sperm based mainly on a subjective motility analysis. So we wonder, is there a better way to select sperm for ICSI? Again, choose one. Now, what if we use tools? What if we use the technology available to objectively track every individual sperm, to follow it, and to compare them in real time to point those sperm that have the best desirable parameters, in particular, motility patterns? Well, this is pretty much SEED. SEED is a computer vision technology that identifies every sperm under the vision field, tracks them individually, while at the same time measuring motility patterns. And according to a ranking, it points to the embryologists those sperm that have the best motility, morphological patterns, in the hope that these will improve fertilization rates and hopefully blastocyst formation. Now, has it worked? Well, after developing SEED, we have used it in a few clinics. And the results that I'm going to present you now are based on videos from one clinic, Boston IVF, and the support of their embryologists. So we took 20 ICSI videos, which were previously video recorded, and we applied SEED. we compare all the motility patterns based on, thanks to seed, and we tried to identify whether there were any relevant differences. What we found after assessing over 3,700 sperm, from which only 84 were selected for injection, we found that practically all motility patterns that were relevant to the embryologists in different proportions, except for STR, head motility patterns, and the rotation of the sperm. Now, we wanted to understand if from amongst those selected sperm, there were any patterns that were associated with a higher fertilization rate, in particular, the formation of 2PN. We found that all the parameters were relevant except for LIN, STR, and HMP. Now, probably the most important question initially for us was whether there are any relevant motility patterns that could be related to an increasing blastocyst formation rate. We found that STR, HMP, and LIN were the only ones that had statistically significant difference with the formation of blastocyst. Why was this relevant? Because practically those were the only ones that didn't seem to be relevant to most embryologists. Now, we developed a seed score, and we wanted to understand whether this new seed score was relevant for formation of 2PNs and blastocysts. We found that there was a significant difference for the formation of 2PN, but with these numbers, there was not enough evidence to support a difference in the formation of blastocysts. So what is our conclusion following our current studies? We believe that seed could become an object of desire because we're assisting embryologists in transforming the qualitative sperm assessment into a quantitative and objective assessment that can be replicated and can allow for standardization in the IVF lab. We're allowing to digitally augment the capabilities for the embryologists. Again, this is not a competition. This is not whether seed is performing better than embryologists or the other way around. We're very, very happy if seed performs as good as a very good senior embryologist. But more importantly, you have to remember that we don't always perform at our best. It's not the same performance that is expected from us when we have a fantastic night of sleep, when we had breakfast, coffee, and we were ready to go, as opposed to when we didn't sleep, we had a fight at home, and we're very tired, we didn't even have time for coffee. And of course, it's unrealistic to expect that we're performing as well in the sperm selection process for the first 5 cases when we have 10 egg collections with 10 eggs each. Again, it's not the same for the first 10 eggs that is going to be our performance with the last 10 eggs. So what if we can digitally augment our capabilities and standardize our performance? And probably even as important, can we learn from seed and improve our outcomes? This is, if seed is finding patterns that were not identifiable by us with the naked eye under the microscope, can we learn new things from sperm and then this knowledge to turn it around, teach seed new things, and at the end, make a team to improve our outcomes? We believe this is the way forward, a collaboration between humans and machines. I want to thank the team of IVF 2.0 for all the videos, for all the work, all the science, and also Jack Cohen for his help and support, Dennis Sakas, and his team, Okayo Okali from Boston IVF. And thank you very much.
Dr. Alejandro, that's a fantastic talk, very exciting. I have a few quick questions for you. It looks like this can be used with a regular ICSI setup. with perhaps just some special software. Is that correct?
Yes. The idea, okay, I am a medical director for a couple of IVF clinics, and just because of the time when the first was built and the second lab was built, even if we tried, it was impossible to have the same equipment. So since the very beginning, we designed our tools to make sure that they could be used in most labs without the need to buy new equipment. So the idea is that seeds should be ready to work in your clinic as long as you have a digital camera attached to your microscope, and that's it.
Okay, fantastic. And with the videos that were taken, were they in PVP already, essentially ready to be ICSI'd into the eggs at that point?
We have played a lot. We have played with, and we have trained seed to identify sperm and extract relevant patterns without PVP, with 10% PVP, 7% PVP, because of the way in which our embryologists make the dilutions, there is a real chance that even if they try very, very hard, that the dilution will be different at the edge of the drop as against in comparison with the center of the drop. There are some clinics that don't use PVP, but they like to select the sperm from the edge of the drops. And we have clinics that only like to have 5 sperm, others 50 sperm. That's not the most common, but so yeah, we have trained seeding in different scenarios.
Okay, fantastic. Okay, Giles, we're going to open this session
Sure,
up for a complete Q&A.
Exactly. Let's start the Q&A, and it's quite interesting because the two speakers, they're from perhaps two possible ends. Perhaps Chaya hasn't got the luxury of talking about sperm that can be diluted, but there is a question, and for you, Alejandro, can it be used with Tesa samples? Has that been tried at all? And what are the dilution factors that you like? Would you say is there any number for that?
With Tesa, with TC samples, one of the main challenges is sperm tend to be immotile. So we believe that the value that we could add is if we could assist the embryologists in identifying where sperm are. So we're lucky if we find sperm. So at this point, we haven't trained seed for that. Again, the training is towards assisting embryologists at identifying where sperm could potentially be as soon as possible. So it can reduce the length of time that they spend looking for sperm.
So it could, in fact, perhaps help people look through the tissue in the future. I mean, again, not what you're doing at the moment, but perhaps you could use image analysis to find that better. Yes,
I believe that the tools that are available today in talking about machine learning, computer vision are fantastic tools that we have to really try to learn from them, and then improve our practices and the life of our embryologists that probably get terrible back aches whenever they have TC cases.
Thank you. Thomas, a question from you?
Yes, fantastic. Hi, we've got a question here from Matt Pettit. He wants to know, when you take the device and place it into a cryo vial and plunge it into liquid nitrogen, is the cap of the cryo vial on tight, or does the vial fill with liquid nitrogen before capping?
This is a bit of a balance, because I do want the vials to fill up with liquid nitrogen, but I don't want the caps to pop off. So they are just short of fully tightened.
Got it. Excellent. And when you take them out of the oil and place them into the cryo vial, is this a messy procedure? Does oil generally tend to get around the vial?
I do try to, I kind of, as I'm pulling it out of the dish, kind of draw it along the lip of the dish to kind of keep it from dripping all over your surface as you move from 1 to 2. But sometimes when you thaw the vial, the device doesn't slide out initially, and that's because there's excess oil that's frozen to the surface of the vial, but you just leave it until it slides out smoothly as soon as the oil thaws.
Okay, fantastic. Thank you.
A question from Bronte Stone. Is the sperm clearly visible on the device? or is there more like searching to be done? Would you have to transfer that to anything else?
Yeah, you can see the sperm, meaning when you thaw them and you're trying to find them to remove them. They're much easier to initially, to find right off the bat when they're motile post-thaw. So that's the best case scenario, but they are pretty easy to find, and that's what we like about it.
Dr. Alejandro, so with the SID device, you're taking the sperm, which is moving in perhaps the best way that the artificial intelligence has determined. And then you're taking those sperm and doing morphology analysis on those. Have you done that?
So SID is an assistant. This means that it will, probably you didn't see in the video, but what SID is doing is that the main screen is choosing and pointing at those sperm that have the best motility patterns. But on the left side of the screen is digitally augmenting the image. So it can assist you in that way to identify those sperm, to better assess the morphology of the sperm. At this point, this is our main focus, motility patterns. And I've used this example before. I know it's terrible, but I think that is very easy to get. If you have a 3-legged dog, you don't have to be a genius to understand or predict that this dog is going to have an abnormal motility pattern. So we have to remember that sperm are moving within a fluid, and this hydrodynamic form or shape of the sperm will dictate in certain manner their motility patterns. So we believe that motility and morphology will be correlated. Now, as an assistant, we're not telling you you should inject this one. We're suggesting, or SID is suggesting that this one has the best motility pattern, so you can immobilize them and continue with your protocol. So you can assess morphology if you want to augment, change the objective and increase the vision. So that's up to you. You have to follow your own protocol. SID should reduce the time we expect between starting a procedure and finalizing the immobilization of the sperm. And we hope it will improve fertilization rates.
Okay, thank you. A question for Chaya now, or the two, but quite similar. It's from Mohammed Hadi Zidane and Danielle Shinan. What's the ratio between the sperm freeze or the vitrification wash medium and the device? And also, can you tell us a little bit, is it a standard vitrification medium, or is it something that you concoct yourself?
So it is a commercially available sperm freezing media, and it's similar to what you would do if you were freezing them in a vial. It's 1-to-1 sperm freeze and sperm wash.
Okay, thank you, thank you. Thomas, can you take the question?
I have a question from Nikia Zanokovic, which is a question about the name. Sorry, how do you, did you train SID for sperm morphology?
Not yet. Again, right now, we're mainly relying on motility because once again, we expect that motility patterns will be directly correlated to a certain extent with morphology. Because at the end, if a sperm has perfect morphology, but is not moving and is supposed to be mature, then that doesn't reflect that well, and doesn't speak that well in regards to overall sperm health. So if you have other options, if you have another sperm that is equal in morphology, but is showing better motility patterns, which one would you select? And once again, since your eyes don't have a speedometer or any objective way to assess this, then it will be just practically like throwing a coin in the air.
Right. Have you taken, for example, 100 sperm from that have been assessed with SID and done morphology analysis on those compared with those which were not selected?
Right now, we have focused those at selection with 2PN and blastocyst formation. And of course, I know that people would love to hear about whether this is increasing or changing euploidy rates or reducing miscarriage rates. But we have to take into consideration that even though we love the research around sperm, we have to avoid falling on the same path that most people have followed in the past, to forget about the sperm. We have to remember that this sperm is going to fertilize an egg, and that the genetic material of this egg cannot be identified in the video that Sid is assessing. So right now, and of course, embryos have shown to be able to repair DNA damage and to restructure some genetic issues at the beginning. So we haven't done that, of course. We want to link seed patterns with live birth. The time will come, hopefully, but we have to take it one step at a time. We first have to understand the impact that individual sperm have on fertilization, on the formation of healthy embryos that can make it to a pregnancy test and then a positive test, and then hopefully which sperm patterns are correlated with that reduced miscarriage rate. And of course, we need thousands of cycles, if not tens of thousands of cycles, to show a difference at this point in those areas.
Okay, excellent. That's a very, very exciting work. So thank you. Giles.
Well, what I'd like to do now, I'd like to share a little bit of information about the network session we're doing, because I know people will start to be entering from the membership card, and there might be a bit of noise going on. Then if there's still time, we can answer a few more questions until we wrap up the session and then go to the network. So if I can just share my screen, I just want to run through, if I may, just a few things which are going to happen after the end here. So we've also said we like to try things new, and we're going to try something out. It's a trial. We're going to try a new way of networking. As you know, I3 have done some networking sessions in the past. This breaks away from the Zoom section, and we have a new system which we're going to try. We're going to give you a link later on and a password, so you can in fact engage with the speakers and some of the vendors as well, who will have in this virtual space. So you can talk all together, or you can sneak off to a corner and have a cluster, as you can see in this picture here. When you sign on with a link, you know, please put your name, something about yourself, and then continue on into the room. The best browser is Chrome. Okay, so I would recommend that. It can be used on your phone as well as a PC. You can zoom in and out, but I'll talk about that later. So you can monitor your camera, you can turn your camera off, or you can turn your mute off, and just join the space, and please engage with us as best you can. Now, on the right-hand side, you'll see all the rooms. There's people here that have spoken today, Alejandra and Chaya, and there's other people who you'll know from our other sessions as well, and from the IVF world. If you cannot see on the right-hand side some of the rooms, then you click on the actual icon, and then they'll appear. And of course, at the bottom, you can hide your camera, and also you'll mute yourself as well. So you can whiz around the room, you can teleport to different rooms, you can zoom in and out. If you have a mouse, that's much easier. And as you see on the right-hand side, you can click into any of the rooms. You can move from side to side, expand, and explore the pictures that you've got there. And you can also zoom in and see closer action when you want to speak to someone. When you speak to someone, you can hear them well. When you move away from that person, that's sometimes when the sound gets quieter. So you have to be close to someone to hear them speak. It's a truly virtual experience. So again, click on those rooms, teleport to those rooms, and hopefully you'll have a good network session. Now, I'm going to give you the link now. It's not ready until the end of the session, so just take it. It'll appear, I believe, also in the chat section. This link will appear in the chat section. You don't have to go there yet because it won't be open. Hopefully someone can place that now until the end on the chat section. That's the link. And the password will be this, okay? Now that's that for now, and I'll stop sharing. We can continue with the Q&A, I believe.
Thanks, Giles. I just wanted to say that when people enter, they will be placed into a random room. And they do not have to stay in that room. They can certainly travel between different rooms, find their friends and colleagues, and learn about either some of our presentations today or from some of our guest speakers in those rooms. Thank you very much. A couple more questions. What do you think, Thomas? Sounds good. If you'd like to go ahead, I'm going to find one as well. Okay. This is from David Russell. Do you think the SID could be combined with a laser system in order to immobilize them? Because, of course, there has been talk for many years about the robotic ICSI, and this is just one tiny aspect of that.
I love this question. I think that there's a lot of research since, well, not that much, but there's some research around the ICSI or the robotic ICSI since a long ago. But at the end, you would still need to manually mobilize a sperm. We believe that SID could potentially become this missing link. And you know that everything around the computers and the interaction with humans is named after human functions. So you have neural networks, you have computer vision, you have everything is around that. So I love the idea of what I like to call an arc reflex, a very shallow neural network with a very quick action that could trigger the mobilization of a sperm. So yes, I think that that's doable. I know how long it would take, but it's doable. Okay, thank you very much. Excellent. I've got a question here from Philip Chan about the sperm. When it's washed, it will start to undergo hyperactivation at some point. So the patterns in the way that the sperm is swimming can change over time. Will this be affected with the SID? You have to remember that SID is a ranking system. What we do is we develop ranking systems. So ERICA is a ranking system for embryos, and it will tell you which embryo has the best potential within a cohort. And for SID, it's the same. This is a ranking system. This means that if you, for any reason, have hyperactive sperm, it will be the same through the sample. So it will still show you those that have the best motility patterns from that specific sample. If for some reason you left unattended the sample and the sperm are moving very, very slow because of you neglected them, SID will still tell you which one has the best motility patterns from that sample. And the same, and this is the reason why it's not that difficult for SID to pinpoint those best sperm based on motility, regardless on whether you are using PVP or not, if it's 5%, 7%, 10%. So it shouldn't make a difference. So fantastic. So this AI really doesn't matter if you've got fantastic sperm, it's still going to give you the very best of those sperm to choose. Or if a patient comes in with very, very poor sperm, it's not looking necessarily for the perfect motion, it's looking for the best of the sperm within that sample. Exactly. I believe pretty much what the embryologist would do. You would only tell the doctor, listen, doctor, you have to tell your patient that the sperm quality was terrible. But now this terrible has an objective way to be measured. And this could also help in containing expectations from the doctors, the couples, from everyone. And again, this will become, I hope, a more objective way to communicate throughout the whole process. Fantastic. Good. And I've got a question for Chaya here. How do you time manage all this work? Because you say, you spend hours looking for the sperm. I mean, can you sort of say how many cases you do a day and how much time would it take? So that's the beauty of being in urology, is I get to schedule my patients and schedule them as we want, and that's so that I'm only working on one case at a time. I don't have 5 other ICSI cases waiting for me. So it takes as long as it takes. I never schedule more than 2 patients a day. And some days it takes me 8 hours for 2 patients. Some days it's 12 hours. It takes as long as it takes. It could easily be, 4 to 8 hours, depending on how much sperm is in the sample.
Great. Okay. Thank you. We have got some more questions, but hopefully they can be answered perhaps in the network rooms. Perhaps people can find them in there later on. What do you think, Thomas?
That sounds good. So we'll wind up this session, and as soon as this has finished, we hope to see everybody in the networking room. So with that, I would like to thank everyone who took part in this webinar: Giles, Chaya, Alejandro, and of course the sponsors, which is IVF 2.0, Maze Men's Health, and MSC Global Limited. We have the links to each of those companies on the i3 website, which is at ivfmeeting.com. Thank you very much to the organizing committee of this IVF initiative. And those people are Jacques Cohen, Peter Naj, Shaista Sadruddin, and Marianne Cervantes. So thank you all for your continued amazing hard work and dedication. So in 1 week's time, we have a very exciting session about green IVF. It is actually going to be split into 2 different days to hopefully cover a little bit more of the world. On Tuesday, the 1st of February, about 1 hour earlier, so at 2 p.m. EST, which is 7 p.m. GMT or 8 p.m. CET, there will be a session on green IVF. That session will be repeated. It will be very, very similar in terms of content. And that will be at 9 p.m. EST on Wednesday, the 2nd of February, which is 9 p.m. EST, 6 p.m. Sorry, 9 p.m. EST, 6 p.m. PST, and 1 p.m. AEDT. We have moderators Dr. Jacques Cohen and Dr. Emma Saunders, and Giles Palmer will also be joining. We have presenters Rosin O'Raghale, and she's going to be talking about how green is your IVF. We also have Ricard Ledin da Rosa in a talk which is sponsored by Vitrolife, and that talk is entitled "Why Does the Sustainable Development Goals Matter for the IVF Business?" We also have a presentation called "Creating a Greener Clinic: The Triple Bottom Line," and that presentation is going to be given by Chip Kalgani. Okay, it seems that we are at 4 p.m. So looking forward to chatting people in our very exciting networking session.